Good afternoon, everybody. Respected chair, respected senior faculty members, friends and colleagues. Greetings from RCC Trivandrum. One word before. Though my topic was anesthesia and cancer recurrence, when I went through this topic in detail, I found that anesthetic drugs and anesthetic techniques has got only a very minimal role in cancer recurrence and metastasis. So I changed the title to Factors Affecting Long-Term Outcomes in Oncosurgery. Greetings from RCC Trivandrum. So in the next 20 minutes, I will cover this topic in the following headings. What are the perioperative factors responsible for cancer recurrence and metastasis? Effects of anesthetic drugs and techniques on immune system. The clinical evidence for these factors on influencing the outcome. And what is in future, what we need in future. So coming to the global scenario of cancer, we know that cancer is the second leading cause of death following cardiovascular cause. So it is said that from 2012, when it becomes 2030, there is going to be a 50% increase in the incidence and 60% increase in mortality following cancer recurrence or metastasis. And 1 in 9 will recur if they survive even though they have a negative margin at time of main resection treatment. And 2 in 9 are at risk of getting a second cancer also. One good thing is that cancer survivors are increasing now, and there is a hope that our treatment is going to be getting more and more effective. And by 2030, it is said that 45 million cancer surgeries are going to happen every year, and that is the big challenge going to be in next future. So to understand the cancer recurrence and metastasis, we should know something about the cancer biology. That means, what is the fate of a cancer cell in the body? The cancer cell, when it enters the body, it may either go to the elimination phase or equilibrium phase or an escape phase, depending on the body's immunological status. And the host defense is to fight with these cancer cells are met through the immune system. There is a cell-mediated immunity which works with natural killer cells, cytotoxic T lymphocytes, the CD4 plus, T helper cells 1, CD8 plus cells, mononuclear and dendritic cells. And the natural killer cells acts through interleukins, interferons, tumor necrosis factor alpha, and forms the first line of defense against these cancer cells. And once these cancer cells are destroyed by the natural killer cells, that elimination phase is over, or that is the elimination phase. If the cells are not completely eliminated or destroyed, at least they will be kept under check, multiplication check by the immune cells, and some of the cells may remain dormant also, and that phase is known as the equilibrium phase. When a pro-inflammatory mediators are released and a suitable microenvironment occurs later on, that will cause an escape phase where these cells under immunosurveillance in dormancy escape from the site and enter the bloodstream and produces tumor recurrence or metastasis, which can be a local, loco-regional or a distant site. All this depends upon the aggressiveness between the cancer cells and resilience offered by the host. The host response can be an anti-cancer effect or a pro-cancer effect. So how does a cancer patient differs from other patients? So we know that the cancer itself has a lot of implications, not just a disease alone, like our hernia or hemorrhoids. So it has got a multi-systemic involvement or effects in the body, and these place these patients at high risk for postoperative complications. Also, they might have undergone a neoadjuvant chemotherapy or radiotherapy. That means chemotherapy or RT given prior to the definitive surgery will make them further more immunosuppressive or further nutritionally poor, and to place these patients again on high risk for complications. And they are on surveillance for recurrence or for a second cancer. So our role is to get back these patients on track as quickly as efficiently and as better as possible to have a correct postoperative care and to undergo the remaining treatment. So how to achieve that? By enhanced recovery program and rehabilitation program, which is set to improve the survival. And regarding what is a RIOT? RIOT is the return to intended oncological treatment. That means following the definitive surgery, the patient has to undergo adjuvant therapy, chemotherapy or radiotherapy at the stipulated time. Probably they will decide the correct time of adjuvant therapy to be given. For example, following 1 month of definitive surgery. So patient has to be brought back to that treatment regime at the stipulated time. That will help a lot in the prevention of cancer recurrence or metastasis. So coming to the perioperative factors, what are the factors which affects cancer recurrence? One is the patient related. We know that the patient will be under severe stress, anxiety and stress, both mentally and financially. So that can affect outcome. Surgical techniques, there is going to be a very extensive surgery. So that also has very adverse effects on the patient's system and immune system, and the duration and extent both are significant. And coming to the medications used during anesthesia and the anesthetic techniques you choose for anesthetizing the patient, and the intraoperative complications like hypothermia, all the issues happening intraoperatively, postoperative period, because we don't know, the patient may be undergoing major cytoreductive surgery, will be on ventilator support and intensive care, postoperative care for so many days. So that may have the prolonged recovery also will have an adverse effect on outcome of these patients. And all these factors affect directly and inhibits the immune system, or indirectly they will enhance the invasiveness and cell proliferation ability of these cancer cells, and also neovascularization in these cells. And is surgical stress the culprit? We know that the surgical stress has got direct and indirect effects on the survival or recurrence of the disease. And during surgical resection time, there can be release of cancer cells into the circulation, what we call CTC, and these cells are dealt by your immune system later on. And even with a negative margin, even though the surgeon have a negative margin, there can be a minimal microscopic residual disease remaining in the body, which can later on go for a local or regional spread. And perioperative factors are also, we have to look into the factors, which is most important is the inflammatory response. Because we know that the surgical stimulation happening during surgery and in the immediate postoperative period, there is severe inflammatory response, the release of a lot of interleukins and inflammatory mediators, even up to a period of 1 week, which can have immunosuppressive effects on the immune system. So along with that, pain. We know that all these patients might be on cancer pain and for cancer treatment with even morphine, so or multimodal analgesia or NSAIDs. So pain should be well controlled during even the preoperative state itself, and well controlled intraoperatively and postoperatively. And the hypotension, the tissue hypoxemia going to happen intraoperatively, and the blood transfusion, hyperglycemia, all can lead to immunosuppression. There can be stimulation of the hypothalamic-pituitary axis and sympathetic nervous system stimulation, which can lead to depression of CMI. So all these effects through catecholamine release, cortisols, prostaglandins, cytokines, hypoxia-inducible factor alpha, and when there is a suitable microenvironment, as I discussed earlier, when there is a microenvironment situation happens, these cells escape and produce metastasis. And this is a chart which shows that surgical incision, following surgical incision, there can be the neuroendocrine response, which release cortisol and catecholamines on one side, and which can favor the tumor growth. And the right hand side, you can see that there is inflammatory response, the massive inflammatory response depending on the surgical trauma or stimulation, which can lead to inflammation, later on immunosuppression, and later on cancer progression by inhibiting the immune system. So this chart will show the interplay of various factors involved. You can see that there is sympathetic nervous system stimulation leading on to inflammation, and then leading on to immunosuppression, and the anesthetic agents causing immunosuppression, and the platelet activation leading on to cancer recurrence. So all these factors have a interplay, and all these result in cancer recurrence. All these cells, I told you that they inhibit the natural killer cell activity. They will cause the cancer cell proliferation, and they can lead to progression of minimal residual disease and cancer recurrence. It is said that the major surgeries, I told you some cytoreductive surgeries or major surgeries, they will be having extensive trauma, extensive inflammatory response, and that has a relatively bad effect on the immune status of the patient. And more complex surgeries, again, all these have a negative effects. And it is said that matrix metalloproteinases are extensively released during surgery. That also has an effect on the immune system. And also, next question comes, does a minimal invasive surgery will help in this context? Like coming to, we're told that there is tumor manipulation is there, which releases cancer cells. So whether there is any role for, or what is the advantage of doing a laparoscopic surgery over open surgery? Does it have any advantage? We'll see later on. So the cancer cells in the body, they can escape from the primary site when there is a suitable immunosuppression status happens. They can intravasate, they can go to the bloodstream, they can go to extravasate and cause a tumor recurrence or metastasis. So this is the chart which shows the surgical tumor excision happening on one side. You can see that the tumor cells are released during surgical excision that can intravasate into the blood vessel, and later on they can get out of the vessel, and when there is a suitable microenvironment settles in the perivascular area, there is a premetastatic niche is there that will trap the cells, cancer cells, and attract cancer cells, and other immunomodulatory cells are there, and they can result in a cancer metastasis formation. So this is one diagram which shows the tumor excision and the effects of surgical stimulation on the immune cell activation. Here you can see that the immune cell activation, there is one arrow which is immune cell activation. Then there is tissue hypoxemia which is happening, and there is pain stimulus. We know that depending on the surgical stimulation, there is intense pain. So that also released activation of HPA axis, and finally all these result in the metastatic growth of the tumor. And so that is the short surgical influence and other perioperative factors which influence. Now coming on to the anesthetic factors. So now coming on to the main crux, how the anesthetic drugs or techniques is going to have effect on the cancer outcome. So inhalational agents which we commonly use for all our anesthetic procedures, we want to know whether it is good or bad. The inflammatory agents, the inhalational anesthetic agents, they release pro-inflammatory agents which can produce immunosuppression. And there can be upregulation of hypoxia-inducible factor, vascular endothelial growth factor, matrix metalloproteinases, etc. And they can depress the natural killer cell activity and the B and T cell apoptosis. And they can alter the ratio of T helper cells 1:2. That means when the T helper cells 1 or more, there is anti-cancer effects are more, there is anti-cancer effect. And when T helper cells are more, there is a ratio is reversed, and there is pro-cancer. There is pro-cancer or favor cancer growth. And there can be modulation of gene expression and stress response attenuation. We don't know how extent that inhalation agents produces stress response attenuation. That has to be studied further. And all these create a pro-malignant environment. That means it can favor cancer recurrence or metastasis. Then coming to the IV anesthetic agent propofol. We know that we are using propofol for induction and maintenance of anesthesia for all major or even minor procedures. So very extensively used. And literature all favors anti-cancer effects of propofol by their anti-inflammatory, anti-immunosuppressant activities, as well as the better preservation of T cell activities seen with propofol, and they can modulate genetic signaling. All these have a positive impact, positive response on the long-term survival and tumor recurrence. So it's a good drug. It doesn't harm anyway. But the current evidence, the current recent randomized controlled trials are not much supportive of these positive effects. Then another one important drug we use particularly for cancer surgery is opioids, particularly morphine. Morphine we extensively use in our center because we have a lot of cancer patients. They are already on morphine, and they are very extensive surgeries that require intraoperative usage as well as the postoperative morphine. So these patients, whether we want to know that what is the effect of morphine on these patients. So theoretically it can produce immunosuppression, but because of the direct effects by inhibiting the NK cell, B and T cell suppression, and inhibit cytokine and PG release, etc. Indirectly, it can depress the HPA axis and sympathetic nervous system activity, and it can stimulate nitric oxide synthesis, and it can promote cancer cell proliferation, invasiveness, and neovascularization. And there is a minimal chance or less chance of the tumor favoring metastasis or going for metastasis, but it is not fully proven. There is no conclusive evidence so far for these effects of morphine. So I think we can just use morphine, but we have to wait for further RCTs on individual drugs, because RCTs are done not with individual drugs of anesthetic drugs taken care of. So we can't say per se whether morphine has any individual adverse effects. So we have to wait for more RCTs to know that morphine can be used or not. Currently, I think we can still give morphine because the benefit of getting morphine is very high when you weigh the adverse effects of that. So coming to other drugs like ketamine, ketamine is said to have a pro-metastatic effect, and it can suppress cell-mediated immunity. And statins, tramadol, steroids has got some beneficial effects, not proven. Blood transfusion, again, there is a transfusion-related immunomodulation happening, and whether it has got any association with cancer recurrence, it has been shown that there is some association, but there is no causation. So at present, there is nothing preventing giving blood, but one thing is keep in mind, it has to be reduced, the usage of blood, because it is an allogenic agent, so it can have some immunological effects. And keeping in mind, you have to minimize blood transfusion only for the need situations. And the periop immunonutrition, definitely it can have some beneficial effects and enhance recovery. Anti-tumor vaccines, some benefits we have to wait and see. So regional anesthesia, whether it is good or bad. We know that regional anesthesia has got offers excellent analgesia, excellent stress response attenuation. You can avoid or reduce opioids and avoid inhalational agents. So it has got definitely a direct immunomodulatory effects of local anesthetics also. Lignocaine and ropivacaine is said to have some good effects, because all these drugs, though you give it regionally, block or whatever, some intravascular levels is achieved. So intravascular lignocaine or ropivacaine is said to have some anti-tumor, anti-cancer cell attacking effect, so which is going to be beneficial. So earlier studies showing was total intravenous anesthesia with propofol and versus inhalation GA with inhalational anesthetic agents has given some hope, but now there no much of the recent RCTs are not much in favor of that. So we have to wait for more RCTs to come out with any harmful or definite better effects of effects of regional anesthesia. Anyway, the meta-analysis and systematic reviews are also indicate some survival, but there is no definite association between them. So local anesthesia, I told, it has got immunomodulatory effects, opioid sparing effects, anti-angiogenic and anti-inflammatory effects, and there is definitely a good effect of recurrent-free survival, but regarding the overall survival, it needs further study. IV lidocaine in a concentration of 1 to 2, in a dose of 1 to 2 milligram per kilogram per hour intraoperative use is found to be beneficial. So coming to the clinical evidence, what the clinical evidence we have, there is when we search the literature, I found that most of the retrospective studies done on animal and in vitro were found contradictory to human studies, as well as previous retrospective and prospective human studies were found equivocal or contradictory to our well-conducted RCTs. So again, we are in a dilemma what is the current status, whether we have to use it or not. So anesthetic techniques have shown that there is only very minimal effects on this outcome. So what the challenge we face now is, because we have only a very low level of evidence, and RCTs are underway, and it needs large multicentral trials. And RCTs, we all know, it is time consuming, it is very costly, and because heterogeneity is there, because various tumors are, various cancers are being considered, and that also will affect the outcome. So regarding the return of Indian oncological treatment, just three more slides. Return of Indian oncological treatment, I told you it is important because we have to get back the patient to the adjuvant treatment in time. So ERAS, our enhanced recovery after surgery, will help you. And the prehabilitation program, which Kishore and Vijesh were discussing, I don't want to focus much on that. That prehabilitation program, because we usually, that is by the trimodal approach, exercise, immunonutrition, and psychological support will help the patient to come back. So our role as a perioperative physician is to negate the perioperative factors. So what are the factors which can be corrected and which can be treated in the perioperative period has to be dealt. And then you have to promote anti-cancer defenses in the host. You use NSAIDs. NSAIDs are said to control the inflammatory response during surgical stimulation. So use NSAIDs, beta blockers, because of the surgical stimulation producing catecholamines, which acts through beta adrenergic receptors, increase the stress response. That can be attenuated by our beta blockers, so found to be useful. Anesthetic techniques, only minimum role. We enhance the functional recovery of the patient and minimize perioperative complications. So the hierarchy of factors affecting cancer outcome are perioperative care, the surgical skills, the patient factors, cancer biology. Out of these four, only two we can manipulate. As an anesthesiologist or perioperative physician, we have a role only in manipulating the perioperative care and patient factors. The surgical skills and cancer biology are not in our hands. So to improve the oncological outcome, we have to medical optimization or prehabilitation. We have to minimize surgical stress. We have to minimize perioperative complications, rapid recovery process, completion of new adjuvant treatment, and close surveillance to have a functional recovery. And for that, we need a multidisciplinary team to work with. The previous speaker was talking about the role of multidisciplinary team in cancer care. We have to work with dedication, commitment, and passion, because we have to have a long perioperative journey, not just a factor or just a technique or just a factor alone in determining the outcome. So in the future, the need of the hour is prospective RCTs and total comprehensive patient care by prehabilitation, ERAS, early discharge, quick return to intended oncological treatment. These are my references. Thank you all. Sorry that I could not finish in time. So 2 to 3 minutes I took extra. But anyway, that's from my side. Thank you. I thank the CON MIDKON organizing team for conducting this fantastic academic feast, as well as the very extended hospitality they offer. So extremely I'm impressed, and I very thanks to all the team members led by Shamshat Begum and all other team. Srijat, I don't want to mention anyone's particular name in particular, but everyone needs a big applause, definitely. Thank you.
Thank you, sir. That was an excellent talk on factors affecting long-term outcome in cancer patients. Like rightly sir said, like most of the studies are the retrospective studies. So, and since we use multiple drugs, we are not able to
focus on individual drug effect of individual anesthetic drugs on cancer outcome. That has not been able to study because we are using multiple drugs. So we have to wait for more RCTs, which are done with one drug, using one drug for anesthetic practice, which is not that possible. So we have to wait for further studies or trials to come.
And sir, most of the in vitro studies, so like some of the in vitro studies are in favorable of TIVA, and volatile anesthetic as such have cause adverse effect on, because it causes immunosuppression. So whether you practice TIVA in your institute or you go practice both TIVA and use of inhalation agents for cancer patients.
One problem with TIVA practice is it's costly. If you are going to give a propofol infusion, it is going to be a costly affair. I don't know how much you can practice TIVA in government setup, but we are not using TIVA as in our routine practice. We still use inhalation agents, but maybe we use opioids. A lot of morphine for head and neck surgeries, and we use fentanyl for other surgeries, and epidural. We put epidural for all, or thoracic epidural or lumbar epidural for all our thoracotomies and laparotomies, and provide extensive and very good post-operative analgesia at least for 4 days post-operative period. We will keep the catheter for 4 days, and we give infusion of local anesthetics as well as opioids epidurally with a infusion pump. So that will take care of the pain and for the 4 days. And we also give multimodal. We, along with the local anesthetics, we give paracetamol or diclofenac depending on the patient's status or biochemical status.
Oh, so when you put the epidurals, whether you go ahead with opioid sparing concept or you give opioids along with the epidural, sir?
We give morphine only for head and neck patients, or because there is no, we can't use epidural, no. So we will go for morphine. Whereas for laparotomy cases, gynecological or GI malignancy, we go for local anesthetics. We give a local anesthetics, ropivacaine, infusion 0.2%, as well as buprenorphine or fentanyl epidurally. As in between boluses we'll give. So we will make our patients absolutely pain-free. There is no pain at all. Or the rest of the pain we can manage the NSAIDs. Give paracetamol or diclofenac suppository. Diclofenac suppository is a wonder drug. You use 100 milligram suppository is available. Even OD dose is enough. So it's going to be a very good drug intraoperatively, as well as tramadol. Tramadol has found some beneficial effects. So tramadol is a good drug, is a good analgesic, synthetic opioid. So try to use tramadol. It doesn't have much harm in the body. So use multimodal analgesia and get the pain out, totally cracked or totally manage the pain. That is one important thing which can have a definitely positive impact on the cancer outcome.
Any questions from the audience? If there are no questions from the audience, thank you, sir, for the wonderful talk. We'll go ahead with the next session.